Welcome to this educational video about double outlet right ventricle, or DORV. DORV is a rare and complex congenital heart defect where both the aorta and the pulmonary artery, the two major blood vessels carrying blood away from the heart, arise from the right ventricle. This means oxygen-poor blood is being pumped to the body, and oxygen-rich blood is being recirculated in the lungs, leading to significant health problems. The exact cause of DORV is not fully understood, but it's believed to be multifactorial. This means it likely arises from a combination of genetic predispositions and environmental influences during the crucial stages of heart development in the womb. Certain chromosomal abnormalities, such as DiGeorge syndrome, and maternal factors like gestational diabetes, have been linked to an increased risk. However, in many cases, the underlying cause remains unknown. In a normal heart, the aorta originates from the left ventricle, and the pulmonary artery from the right ventricle. This allows oxygen-rich blood to be pumped to the body and oxygen-poor blood to the lungs. In DORV, because both major arteries originate from the right ventricle, the circulation becomes abnormal. Oxygen-poor blood is pumped to the body through the aorta, leading to cyanosis, a bluish discoloration of the skin. Additionally, the presence of a ventricular septal defect, or VSD, which is a hole between the ventricles, can influence the flow of blood and the severity of the condition. The interplay between DORV and the VSD creates a complex circulatory pattern that demands careful assessment and treatment. DORV is a relatively rare heart defect, occurring in approximately 1 in every 10,000 live births. Due to its complexity and variations in presentation, accurately determining the precise epidemiological data can be challenging. Studies suggest no significant difference in prevalence between males and females. While DORV can occur in any population, certain genetic syndromes associated with heart defects may increase the risk in specific groups. The signs and symptoms of DORV can vary widely depending on the specific anatomy of the heart and the presence of associated defects. Common symptoms include cyanosis, or a bluish tint to the skin, lips, and nails, rapid breathing, shortness of breath, poor feeding, and failure to thrive. Infants may also experience fatigue, sweating during feeding, and heart murmurs that can be detected during a physical examination. The severity of symptoms often dictates the urgency and type of intervention required. Diagnosis of DORV typically begins with a thorough physical examination and listening for heart murmurs. Further diagnostic tests are essential for confirming the diagnosis and evaluating the specific anatomy of the heart. These tests may include an echocardiogram, which uses sound waves to create images of the heart, an electrocardiogram, or ECG, which records the electrical activity of the heart, a chest X-ray to visualize the heart and lungs, and cardiac catheterization, which involves inserting a thin tube into a blood vessel to measure pressures and oxygen levels within the heart. MRI and CT scans may also be employed for detailed anatomical assessment. DORV can be classified based on the relationship between the VSD, the aorta, and the pulmonary artery. The Taussig-Bing anomaly is a type of DORV where the VSD is located near the pulmonary artery. The VSD may also be subarctic, meaning it is located near the aorta, or doubly committed, near both vessels. A subpulmonary VSD, sometimes called a remote VSD, is further away. The classification is vital because it is a key factor determining the surgical approach. The presence of pulmonary stenosis, a narrowing of the pulmonary valve, also influences the type of surgery needed. The primary treatment for DORV is surgical repair. The specific surgical approach depends on the type of DORV and any associated defects. Common surgical procedures include rerouting the blood flow within the heart, closing the VSD, and creating a tunnel to direct blood from the left ventricle to the aorta. In some cases, a staged repair may be necessary. This might involve initial procedures to improve blood flow and then a subsequent surgery for complete correction. Post-operative care includes close monitoring, medication to support heart function, and regular follow-up appointments with a cardiologist. Currently, there is no known way to definitively prevent DORV, as the underlying causes are often complex and multifactorial. However, women planning to become pregnant can reduce the overall risk of birth defects by maintaining a healthy lifestyle, including taking prenatal vitamins with folic acid, avoiding alcohol and tobacco, and managing any pre-existing medical conditions like diabetes. Genetic counseling may be beneficial for families with a history of congenital heart defects. The prognosis for individuals with DORV has significantly improved with advances in surgical techniques and medical management. However, the long-term outcome depends on the complexity of the heart defect, the success of the surgical repair, and the presence of any associated conditions. Regular follow-up with a cardiologist is crucial for monitoring heart function, managing potential complications, and ensuring optimal quality of life. Recent research focuses on improving surgical outcomes, developing less invasive procedures, and gaining a better understanding of the genetic factors involved in DORV.